Welcome everyone to today's webinar, Victim-Informed Strategies for Responding to Young Victims and Families, Research Findings from Illinois' OVC Linking Systems of Care for Children and Youth Demonstration Project. My name is Susan Howley, and I am the Project Director for the Center for Victim Research. The Center is a one-stop resource for victim service providers and researchers to connect and share knowledge. It's a partnership between researchers and practitioners based at the Justice Research and Statistics Association, the National Center for Victims of Crime, and the Urban Institute. This webinar and the research that is going to be reported on during it are both supported by funding from the Office for Victims of Crime. Of course, any of the remarks, findings, conclusions represented here today are those of the contributors and do not necessarily represent the official position or policies of the U.S. Department of Justice. And with that, I'm pleased to welcome today's presenters, Amanda Vasquez and Paula Baldo. Amanda and Paula are both research analysts at the Illinois Criminal Justice Information Authority's Center for Victim Studies. So, welcome, and I'll turn it over to you two.
Great. Thanks so much for that introduction, Susan. So Paula's going to go ahead and get us started by providing a little bit of background information about the demonstration project and then getting into a little bit more specifics of Illinois' involvement as well.
Hi, everybody. This is Paula speaking right now. So I just wanted to thank you all for joining us. Like we mentioned, we are from the Illinois Criminal Justice Information Authority, ICJA for short, and I just wanted to give a brief background into our agency. So we are a state agency, and we basically have two main functions. We're a state administering agency, and so we receive and allocate a lot of different federal and state justice-related grants through our grant-making functions. And we are also our state statistical analysis center. So we have a research and analysis unit, and that's where Amanda and I are currently housed. And we conduct and disseminate different research studies and reports, and we also inform our grant-making functions and programming. And one of those project currently is this Illinois HEALS initiative, which is what we're going to talk about today. And HEALS just stands for Helping Everyone Access Linked Systems. So actually, just out of curiosity, we're kind of wondering how many of you here work with children and youth in your organizations, or if you're researchers like us, how many of you focus on this population? And if we could please use the hand-raising feature. We'd love to get a sense of who we are or who we have in the audience. So we're seeing a few hands here. Thank you for sharing. Quite a few of you guys. So we're hoping that you find this webinar informative, and hopefully it would resonate with you in your spaces. So I'd like to start with a broad overview of Illinois HEALS project, and later on we're going to go into some of our findings. So in October of 2017, ICJA received a Linking Systems of Care for Children and Youth demonstration grant from the Office for Victims of Crime, and Illinois is one of the 4 states who are currently doing this project. So I wanted to send a quick shout out to our sister states. We have Montana, Virginia, and Ohio who are also doing this project. And our goal is to improve our responses to children, youth, and families who have been impacted by violence. This project includes a 15-month planning phase followed by 5 years of implementation, and it has been a joint effort between research, which is us, and our program and policy team, our other half. And we also try to be as intentional as we can with ensuring that this project is really informed by as many relevant stakeholders as possible. So that includes service providers, people with lived experiences, other experts, other researchers as well. So we just really wanted this project to be guided by as many voices as possible. So traditionally, when an individual experiences harm and then they decide to seek out help, this is usually the kind of response that they and their families will usually encounter. So one that is very segmented, very disparate, and the more complex their needs are, the more services they might need to reach out to. And the burden really is on them to navigate these different systems. And by systems, we mean child welfare, education, healthcare, the justice system, civil and legal, or civil and family courts, social services, and victim services. So really, it's the whole gamut of systems. And these are basically just those large systems that tend to work in silos. They don't really work together. They don't share information, at least not often. And I mean, granted, there are those exceptions to this, and that's definitely really great to hear and learn more about. But here in Illinois, our systems don't always collaborate, unfortunately. But our aspiration here with Illinois HEALS is to connect these different systems together so that there's no wrong door that someone can enter to receive the services that they need. Here, the system really takes on the burden away from the family and the victims themselves to coordinate services and the resources that they might need. So, like, we know that there's tons of great initiatives out there that have these similar goals, and we've learned about that through, just meeting with a lot of our stakeholders, like learning about what projects they're working on. So we're actually also curious in your organizations or in your communities if these linked systems or something similar actually exist. And please use the hand raising feature again, as well as the chat box if you have any details that you'd like to share about your linked systems. And we'll be here taking notes because we'd love to hear more about them. So we're seeing a few hands again. We'd really love to hear more about these systems because the more lessons that we can learn from you and your organizations, the better we can make these projects. So we're not really duplicating efforts. We're just kind of learning from everybody else and building on that knowledge base. So thank you for sharing. So as I mentioned in the beginning, this is a multi-phase project. We recently completed our 15-month planning phase, which included leadership network meetings. And our leadership network was kind of like our steering committee. It included representatives from other state agencies, organizational leaders, also people with lived experiences, and they really just helped us inform our process along the way. We also conducted a survey of direct service providers here in Illinois just because we wanted to explore what our current service landscape looks like. Because we as researchers, we tend to just ask a lot of questions, and that was one of our questions. And the more conversations we had, the more meetings that we were attending, really, the more we learned about our state. We actually realized that one statewide approach, at least for Illinois, just won't work. One, because we're a really diverse state, and we also recognize, again, that there are these many similar projects that are already happening, and we didn't want to reinvent the wheel, and we didn't want to start from scratch. So to start, we identified 2 high-need areas. They're basically these large geographical areas in Illinois that had pretty high victimization rates, But we also wanted to see some movement towards systems collaboration or organizations finding ways to work well together. And within these communities, again, we met with a lot of different service providers, spoke with a lot of stakeholders, and we also tried to map how children and youth move through the different systems, which was actually so much more complicated than I had anticipated because of all the different pathways that someone could take when they are receiving services. So this is just the 2 high-need areas that we have identified. We started to focus on Cook County. It's up there on the upper right hand of the map. This is where Chicago is. So there's need and there's also the population density. And then we also focused on the southern region of the state. And this isn't really an exact representation of all the counties that we've kind of had involved down there because some organizations touch different counties. So this is sort of just an approximation. And likewise, there's high need, relatively few resources, and some agencies and organizations down there actually serve multiple counties. So sometimes that means, unfortunately for clients, if they needed services, they would have to travel to the next county. And depending on how many services they're engaged with and how far away those services are, that could be a huge barrier for someone in a rural area where public transportation isn't very easily accessible. And finally, the core of really my and Amanda's work had been this research piece, where what we were finding was directly informing the Illinois HEALS project. So our process truly had been iterative in that everything we were learning were informing our next steps. And this is just a brief summary of our research activity. As I mentioned, we rolled out the direct service provider survey in the spring of 2018, spring of last year. And the survey asked about different types of services and programming that they might offer, their service population, whether they're participating in learning collaboratives or multidisciplinary teams, and things like that. We also conducted a thematic analysis of all our meeting notes, and we were in a lot of meetings, so we had a lot of notes. And doing this just really allowed us to identify emerging themes that was fed directly into informing our process. And finally, we conducted 65 one-on-one interviews with young adults and caregivers who have been impacted by harm. And now I'd like to turn it over to my colleague Amanda, who will start talking about these interviews.
Great, thanks so much, Paula. So as Paula said, today the bulk of what we're really here to share with you and talk to you about is findings from the Young Adults and Caregivers study, which is that in terms of that portion of all those research activities, it's that bottom piece, the research interviews. And so this study, refers to interviews that we conducted with young adults and caregivers living in Illinois. As Paula mentioned, we did interview 65 young adults and caregivers, and we endeavored on that about this time last year, so last May. So our kind of an anniversary of sorts. And then we, I think, closed up our last interviews in January. So did some active interviewing for about 7-8 months or so. And so just to kind of give folks an idea of some of the areas that we were trying to learn more about through these interviews, we were hoping to learn more about the systems and organizations that children, youth, and families have contact with following their experiences with harm. We wanted to understand how systems and organizations respond to young victims and families, including also, what services are available and what services are accessible. And then, really importantly, is to document recommendations that victims and families have for improving how systems and organizations can respond. What are things that they can do to improve recognizing harm? How can they make improvements to ways that they are connecting clients to services and then keeping them engaged in services? as well. So just some background information around, how we went about recruiting folks and then what that kind of looked like. So young adults aged 18 to 25 and caregivers of children under 18 were invited to complete an online survey. And so in that survey, young adults were asked information about their experiences with harm. And it was kind of, we cast a broad net and included everything from neglect, verbal abuse, exposure to violence, in addition to some of those other types of, violence that you're more accustomed to hearing about, like physical and sexual abuse. We also asked about their contact with different systems, and so as Paula mentioned, that ranged everywhere from child welfare, victim service providers, educators, so kind of almost all the systems you can think about. And then for caregivers, if you were a caregiver of a child under 18, we were also interested in hearing from you about the experiences that your children had, both in terms of any experiences with harm they may have had, and then their contact with systems following the victimization as well. And in total, we had about 125 or so young adults and caregivers that completed that survey. And young adults who did report having experienced harm, or those caregivers who indicated their children had experienced harm, were invited to provide their contact information if they wanted to be contacted for a paid interview. And in terms of selecting participants for an interview, we considered a couple of different things. One was the types of victimization they may have had, trying to get kind of a range. Then also the systems they had interacted with, and then their geographic location as well. Because remember what Paula was saying about those 2 high-need areas. We also took that into consideration. And then next, just kind of some brief information about who are the participants that we interviewed. So we did kind of have a pretty even split, wasn't intentional. We had 32 young adults and 33 caregivers. Most participants did identify as female and heterosexual. But then for our young adult participants, 1 in 5 did identify as LGBTQ. Average age of caregivers was 41, but that ranged anywhere from 26 to 70. And then young adults were anywhere from 18 to 25 with an average age of 22. And the reason for that kind of range is, once again, we recruited for 18 to 25-year-olds. We did find that more caregivers identified as African American, and we had more young adults identifying as white or Hispanic. And I just wanted to note here, I'm sure folks are seeing that the percentages do total to more than 100% because participants could select more than one racial identity. And you see here most interviews were conducted with participants living in Cook County, and a quarter of interviews were conducted in that southern region of the state. And I think we mentioned this a few times, but that's because those 2 areas we had identified those as high-need areas, and so we kind of matched our recruitment with some of those areas as well, so we had a higher response. And so kind of getting into some of our findings now. So just to also caveat the next few slides with the graphs or the charts, this is information that we obtained from the online screener. So we didn't ask during the interviews for this information specifically. This was obtained beforehand. So here we see that young adults were asked to indicate whether they had experienced, these different types of victimization, and this was at any point in their lifetime. And then caregivers were asked to report about whether any children under 18 had experienced these victimization types. And just to note here that we asked caregivers to report about any of their children. So these numbers could represent, like for each caregiver, they may be talking about more than one child, or they could be talking about more than one child that they care for. So based on their responses, we see that young adults reported physical abuse, verbal abuse, and witnessing harm is among the top 3 types of victimization that they'd experienced. Once again, this is at any point in their life. Caregivers reported their children were most likely to have experienced verbal abuse, witnessing harm, and being threatened. So there was pretty good overlap in terms of the top three there. So not a lot of differences. It's more so when we get to some of the other things here. I find these pretty interesting. So here we see that more young adults reported neglect, sexual abuse, sexual assault, and witnessing homicide than caregivers reported for their children. And so, we didn't specifically ask about this during, we kind of let folks guide the interview and talk about the different types of experiences that they wanted to, but we have some thoughts on this. Why some of these differences may exist. This could be because young adults are older, so they're aged 18 to 25. And if you're talking about caregivers reporting about their children are only up to age 18. So it could just be that they've had a longer life history, and by virtue of that have had more opportunity or had more victimization experiences. Also, another idea is that caregivers may be unaware that their children have experienced certain forms of victimization. So in particular, maybe sexual abuse or assault, children may be less likely to share that information with their parents. And then also, thinking about, why would there be a difference in terms of neglect? And one thought there is that caregivers may also be reluctant to report past or current neglect of children in their care because they might be fearful of, what that means of a punitive or a stigmatizing response. And so moving on to this again is from that online survey, but this focuses in on the different systems that both young adults and caregivers may have had contact with following their victimization. So young adults were asked to indicate, like I said, whether they had contact with providers, and caregivers were asked to report on behalf of their children. We see that more than half of caregivers reported the children they care for had contact with child welfare, also with the education system and healthcare providers following victimization. And this is, higher than our young adults who were only about a quarter to a third for those same different systems. And so, thinking about this, maybe caregivers may have reported. Some of the caregivers we interviewed had, by virtue of how we did our recruitment, had greater child welfare system contacts. I see a question here. I'll answer in just a second. So caregivers may have had greater child welfare system contact because of how we recruited folks. So we had some instances where the person we were interviewing were actually foster parents, or there was an ad hoc type of arrangement. So they were more likely maybe to have had some child welfare contact. And then also, in talking with families, we found a lot of times that children with child welfare system involvement, they're going to have more contact with schools or healthcare providers who are going to have an understanding of their victimization background. In here, just pointing out a few things related to our young adults who completed the survey. Young adults were most likely to report having contact with a social service provider than any other type of provider following victimization. And so one of the things that makes us wonder and think about that maybe perhaps social service organizations might be a good touch point for young adults who've experienced harm. So this might be a good route to connect them with services. We also found that young adults were more likely to report having contact with the victim service provider. So 1 in 3 young adults compared to a quarter of caregivers. But if you remember back to a slide or two ago, young adults were also more likely to have reported sexual assault and sexual abuse. And so in Illinois, historically, most victim service funding has supported our domestic violence and our sexual assault agencies. And so if you kind of put those two pieces together, because young adults are more likely to have had a sexual abuse history, it might make sense that more young adults would have also had contact with those victim service providers. And then I'm going to turn things back over to Paula, who's going to provide our framework for our analysis.
Thank you. So this is kind of the framework that emerged out of all of our conversations with providers and stakeholders, as well as all of our young adults and caregiver interviews. So what we've learned is that for strong linkages to exist in a meaningful way, all three of these components need to be present. And we will go over these in the following slides, but here we have identification or some kind of identification that harm has occurred, a referral to some kind of resource, and support services. But what we found really interesting, what we've also found is that these components are actually rooted in trust and relationships. So through our interviews, we learned that what victims and their families needed was more of a relational approach to identification, referral, and support. And that is recognizing, connecting, and engaging. And throughout this presentation or webinar, you might hear us refer to this as the RCE framework, just to shorten it up a little bit. So first, instead of identification, we have recognition, and this is learning that someone has experienced past or recent victimization. And I'd like to share a quote from one of our interviews. This is from a grandmother whose granddaughter was experiencing abuse and neglect at the hands of her father, and she shared that two providers came to investigate, so they called the dad to ask if they could come over. Dad said, not right now. And then they said, okay, we'll come 2 days from now. So this actually gave them a chance to, make the home presentable for the investigators. And then she also shared that if only the providers recognized at the time that her granddaughter might have been experiencing abuse and neglect in the home, a lot of trouble could have been avoided. So to us, this really speaks to early recognition of harm so that we can hopefully divert someone into services or any other resources early on so that they don't experience further harm. These are some of the nonverbal indicators that we've heard through our interviews, your red flags, if you will, that could potentially be a sign that someone's experiencing harm. Recognition really is not just about an individual disclosing or someone taking the initiative to share that they've been going through something. It's also really about a provider or any adult or peer in someone's life who might be able to see these red flags and realize that they might be indicative of something more serious. But of course, we know that sometimes that these might be pretty innocuous. So for instance, bruises and scars don't always mean that someone is experiencing harm. It could just be a kid being a kid, accidents happen, I would know because I'm very, very clumsy. Or if someone is withdrawn or angry, it doesn't automatically mean that someone is being victimized, right? So here I guess the main takeaway is that knowing about these red flags might allow us to recognize whether they are different really from someone's usual normal behavior or affect. And learning to recognize them might actually prevent future harm. And these are actually some of what we've heard from our interviews. But again, we're wondering if any of you have seen or learned about other nonverbal indicators in your spaces. And we would appreciate it if you could send them over chat. And again, we'll be taking copious notes.
We see a question. Do these nonverbal indicators pertain to 18 to 25-year-old young adults? That's kind of hard. That's a good question and hard to unpack. These nonverbal indicators would be caregivers reflecting on things that they noticed with their children, and then also young adults reflecting on their past behavior. So these are reported by 18 to 25-year-olds, but on behavior when they were younger, so as a child or a teenager.
And we're definitely still sifting through the data. We're finding more and more every day. And I saw body language and showing affection, so that I think that actually came out on some of the later interviews that we were looking through.
Yeah. Yeah, thanks for sharing these. It's always great to have this continual list of things to sort of be aware of and look for. Yeah.
All right, great. And so please keep sending those. We'd love to have them. I believe I mentioned earlier about how RCE, Recognize, Connect, and Engage, is rooted in relationships. And this is because building trusting relationships also opens the door for us to be able to ask directly about whether or not someone is experiencing harm. And we learned, again, through our interviews that we were really constantly hearing from folks that if only somebody had asked them if they're being abused or if they're going through something that might be potentially traumatic, they would have been open to sharing that experience. But unfortunately, for many of them, the opportunity to ask was often missed. And not only that, but sometimes asking once might not even be enough. So building these relationships, someone might not really be comfortable sharing their experiences right away. So it might be necessary to keep asking, keeping that door open for when that person would feel comfortable enough to share. Our second component of RCE is connecting. So instead of a referral, which could sometimes mean just handing someone a piece of paper with names and phone numbers on them, connection is linking a victim to services or providers who can meet their needs. This suggests that there's some kind of a warm handoff, or one provider calling another provider. And I think this really just helps address some of the barriers to connecting to services if some of the burden is taken away from the person trying to connect. Because it's difficult enough to disclose, but it's also just as difficult to even try to reach out for help. But we do have this common thread that we found, and it's this reluctance to connect to services, and this may be due to a whole host of reasons. For instance, fear of consequences from reporting, especially when it comes to child welfare. There's this perception that the child welfare system really only takes away children, but they don't often know that it can actually be used as a resource. And we've heard from others who believe that they don't really need services because either they don't help them, they don't find them helpful, or that services really just aren't for them. So they would take other approaches to healing or other ways to cope, or sometimes just no services at all. And finally, some folks really benefited from someone who can help them navigate these different systems, especially in its current state here, where everything is so siloed. And here's another quote from a caregiver who was finding it particularly difficult to find appropriate services for her son. They were facing some challenges, lots of different barriers, some legal, financial, and educational issues. And so it made it even more difficult for them to find appropriate services. But then they became involved with a program who had someone that we just ended up calling a navigator, who helped open the doors for them. And this caregiver shared that the navigator was really knowledgeable about what kinds of resources were available in their community, what's accessible to them, including any sort of statutory relief or laws that they might be able to use. And also, this navigator has those really important relationships already with other providers, so connecting to services was a little bit more, was a little bit easier for them. So in the end, it was just this great burden that was lifted off of her and her family's shoulders. And with that, I'll turn it over back to Amanda for service engagement.
Yes. So the E in recognize, connect, and engage. And so when we talk about engagement, we in Paula kind of provided a little bit of context too, but providing services, so services, medical care, counseling, legal assistance, to victims to meet their needs following victimization, but also doing so in a way that is accessible so folks get there. Is it in their language? Client-driven, who's driving the services, who's making the decisions, and then adapted to meet each family's unique needs. And so here's what we've heard from victims about what has impacted their ability to stay engaged in services. And so in talking with our participants, young adults and caregivers described having certain basic or fundamental needs. We all have those, right? Shelter, things like running water, something as simple as school supplies. Some folks talked about the importance of having furniture, like a bed for your children to sleep in. That's really important. And they said that these needs were truly priorities. And so while services to help in healing from trauma were viewed as important, that trauma-focused work was really seen as secondary to getting their basic needs met. And so providers who hoped to engage families that were really struggling to meet these most basic needs often found they could build trust with families by helping them to address those needs. And so, some of our families that we interviewed were really fortunate to have providers that had access to flexible funding. So these providers were able to directly pay for certain expenses. And then, once these most basic needs were met, providers could really begin the work of addressing the impact of that trauma because, those fundamental needs were met and families could actually begin the trauma work and move on to kind of step 2. And then also the sense of trust had been built, that the provider genuinely cared about their well-being. And then also this reassurance that if another basic need arose, providers could help them address it. They wouldn't be kind of referred out or moved here and there. It was really something that they could depend on. And then we heard a lot about, this lack of accessible services as a barrier to engaging or staying engaged in services. So some examples were, some had difficulty getting help because of things like eligibility. One mother said that she made too much money to qualify for certain types of legal aid. We had a young adult who actually worked in the mental health field who said that her insurance, ironically didn't actually cover mental health care. Several caregivers described being unable to get financial support for the children they were caring for because they didn't have legal custody. So it seemed almost as if there was a gap. You don't want to necessarily have children in your family turned over to child welfare services, but sometimes in order to get those services, that so you're kind of stuck in that place. Others said that they needed support services to access services, things like a bus card or gas money just to get from point A to point B. Or what about, child care for children, whether that's you're a parent who needs to get services for yourself, but you have children, or, what about younger children or older children that you have when you're trying to get services for a different child. Many also just described a genuine lack of services. Some said they don't have those services in my community, and they'd have to travel across town, or as Paula mentioned, maybe go to a different county. We've heard of instances where you'd have to travel, and I'm curious to hear from folks here if that's true in your states as well, or where you're at, but having to travel out of state or having to travel, from tip to tip. And Paula and I have done this drive a bunch of times. But, it's a good 5, 6, 7, 8 hours, depending where you're starting from, having to go from the southern end of the state up to the northern end because, that's what folks are saying, those are where the resources are. That can be a real barrier. And then kind of lastly, even when services were available, options could be extremely limited. So one caregiver described how there was one local therapist, so one program in her area, and unfortunately that therapist just didn't meet her child's needs. I think it was more like rapport, and they never quite felt comfortable, but there was no alternative to that. And so, yeah, I'm curious to hear from folks if you wouldn't mind using the chat box to share other barriers to service engagement that you may have observed in your work. I'm curious to see if maybe in different spaces, there's similarities or differences. If you want to just type those in and we can look them over later. And then in terms of services really focusing on the victim, but not necessarily recognizing that harm impacts the whole family. So we know entire families can be impacted. Family members may witness a loved one being harmed, and this type of indirect exposure to harm can have negative impacts. Other times, family members experience secondary trauma or stress from hearing about the harm that's done to their loved one, or even seeing how their loved one is being impacted by the harm that their loved one personally experienced. And so kind of despite that, young adults and caregivers noted that many providers were really only equipped to address the needs of primary or direct victims. So sometimes this meant, the adult could get services, but there wasn't service for the child and vice versa. And here's a quote of a young adult describing staying at a domestic violence shelter. And so, the shelter provided, housing for the family, but they didn't have any specific services, no group work or anything for the children, which she saw as a huge gap and something reflecting on would have been really helpful. And so what does all this mean? So one of the things that Paula and I really like about this project and the work we've been doing is that this is kind of the culmination of that 15-month planning period, or the findings are. But there is up to 5 years of funding in terms of, for implementing some of this. So we get to take these findings and think about what does that mean for the future of implementing a project where you have linked systems. And so these are just some of the, the implications, we see. One is that, you've heard us say this over and over again at this point, but that relationships are really key to learning whether someone has experienced harm. And so this really means prioritizing relationship building. So children and youth who have experienced harm, feel comfortable sharing sensitive information. And it might enable some of those providers to better recognize when a change in behavior or affect might necessitate further follow-up. And so, thinking about how this kind of applies directly into our work, maybe this means, for example, schools, child care providers, recreational staff that spend a lot of time with children and youth could play an important role in recognizing harm. And so maybe that means training for staff, and maybe that means making sure that those folks have information on how to make meaningful connections to services. Also this idea of system navigation. Having someone whose primary job function is to coordinate care can help families to navigate confusing and complex systems and programming. And, as we mentioned, the whole idea of the burden. So, transitioning the burden to find and connect with services from that, from the person who is experiencing harm in that family to the system, to the provider, can be a huge relief for folks. And then lastly, our last implication here, the service co-location, having multiple services or multiple providers in one location, the idea that this has potential to really increase service engagement. So these additional services perhaps could be located within places that families naturally interact with. So maybe schools, doctors' offices, and this might mitigate barriers to service engagement. Which, we talked, or I shared a little bit about, could be things like limited resources for transportation, or even the time it takes to travel from the southern part of the state to the northern part of the state. Also, having these services on site could also increase families' knowledge of services, what they are, what they do. So maybe if they're, were reluctant to connect with services, maybe they were afraid of, they didn't know what that meant. Maybe they didn't think services could help them, or they weren't for them. But kind of, seeing other people going in, or getting those services and just seeing what it's about could maybe facilitate connections and engagement. And with that, I'm going to turn it back over to Paula one last time, and she's going to kind of walk us through on how RCE, our Recognize, Connect, Engage, and these implications, how we integrated them into an action plan for our implementation period.
So soon to be released is the Illinois HEALS Action Plan. It's in the review and approval process now, and because we are a state agency, that means a lot of waiting for review and to be approved, but it's coming out very, very soon, and we're all very excited. And it's basically a very comprehensive account of our whole process, what we've learned, what we'd like to accomplish in our implementation phase, and things of that nature. But what we have here are our 6 main goals. I want to reiterate that we're not really taking a statewide approach. We're starting very small. We're starting local. We really wanted this to be very much community-led and community-driven. So what do we have on deck for this phase? Well, we'd like to build a local system of care. And for the purposes of this project, we define system of care, and please bear with me as I read this from our action plan. It is a coordinated, multidisciplinary group that works collaboratively to develop cross-system policies and procedures that improve access and quality of services for victims and their families. And again, we totally recognize that there are already some really great and exciting initiatives out there that are kind of similar, and we really don't want to just ignore those lessons learned. So we'd really like to support or enhance what we can. So again, we're not duplicating efforts, and we're not constantly starting from scratch. Goals 2, 3, and 4 here seek to strengthen recognition, connection, and engagement of victims, so the RCE framework that we were just kind of speaking about. And this could be through community awareness events, trauma-informed training, multidisciplinary team approaches, and Amanda talked a little bit about co-location of services, and we think that the possibilities are pretty endless. Goal 5 is our research goal, and because this is a demonstration project, we want to learn as much as we can from what we're implementing. So we're building in a process evaluation that would inform implementation itself. And so hopefully it would result in a toolkit for other communities to be able to replicate our process. And finally, goal number 6 really speaks to sustainability. Again, we're starting small to go big. The importance of relationship building really isn't just about clients and providers or between providers themselves, but also between systems. And we're hoping through this project, we'd like to promote systems to really work together and be collaborative, not just cooperating with each other, but true collaboration. So this is an expanded version of the 5th goal, our research goal, and each of the goals that we have in the previous slide comes with this expanded version in our action plan. But because we're the researchers for the project, we figured we'd speak to this 5th goal. And I just want to go over this very briefly. I know we're close to the end here, but for the implementation phase, our role is to establish this feedback loop with our demonstration site, our program and policy team, our stakeholders, our national partners, so that they're informed of how implementation is going. So this could be identifying needs and gaps, identifying best practices, working with our demonstration site to help them develop their project designs. Because it is community driven, we want them to take ownership of their process and of the project. Making sure it's in alignment with our action plan, and starting to measure some preliminary outcomes to see if our approach does help improve our responses to victims. And of course, we will be consistently feeding this all back to our partners to see what's working and what isn't, or if we need to change direction. And like I mentioned earlier, we'd like to come out of this with some kind of toolkit that would enable other communities to be able to replicate it.
And we're starting with one, as Paula mentioned, one demonstration site as well, and hopefully learning as we go, and hopefully moving on to other communities as well. in the future. So that's more of a long-term goal. And I think that for the most part brings us to the end. So this is our contact information. Paula is the Illinois HEALS point of contact in terms of the research piece of that moving forward. And we do have, if folks are interested, we do have a specific Illinois HEALS website. So it is just www.ilheals.com. And so we will be posting, I'm not sure Paula what's on there right now, but we have some basic information, and we'll keep things updated. We have a newsletter that we are publishing. I think we're trying to publish quarterly, and then that's where our reports, our action plan, and subsequent reports will be posted as well.
That's great. Thank you both, Amanda and Paula. And now, as I did mention to people, while we take time for some questions, we will be launching our exit poll. So do make sure that you take that poll before you officially exit, and then use the chat box to enter your questions for our presenters. We did have a couple of questions come in already during the presentation, so this will be a good time to raise them. The first was, how might someone find out if they have any linked systems, and how might providers initiate such a model in their state? I mean, you all and 3 other states were lucky to have large OVC grants to do a statewide project. But what do you think it would take?
It's the process. It is. I think it really is it's just about relationships, like Paula mentioned, even within. So it's just starting to have conversations and reaching out. And that's kind of, I think, how it's almost like a snowball effect. And I think one of the things that with our agency, we are a convener of sorts. So we do have a board that does have different system heads and things like that. So I would actually probably look to see if there's something similar in your state. So if there's an agency that convenes folks together. So we're, the Statistical Analysis Center for the state of Illinois and the state administering agency as well for different federal grants. And that varies from place to place. That might be a place to see if they do similar work, but it may be, really housed someplace else. But yeah, I would look for a convener. To see where you can start and make connections, because they'll already maybe have some relationships built, and you can kind of go from there.
Yeah, also, through this project, we've learned about all these other initiatives that are doing something similar already, and what we found is that folks are really interested in working together. There's just a lot of barriers that come with working together, but there's at least that interest to be collaborative. So I think that if folks are able to, have other initiatives that are doing this and maybe also partner with them, it doesn't have to start at the state agency level, but we think there are some really great initiatives out there that are doing something similar.
And I would add too that we in no way, shape, or form knew of all of the collaborations that existed. So when you do start to talk and ask questions, we were really pleasantly surprised by all the work. So sometimes it's just sort of uncovering what's there. Sometimes.
Oh, that's great. In the conversation about the indicators that people could look for, we had a question: what about those who hide it so much that they mislead or potentially lie about parts of their life in order to feel normal? Did you have any input from some of your partners about that?
That is a tough one. There were folks that I think were, did describe that behavior that you're talking about. Sometimes I do think, not all the time, but sometimes I think it's also meeting folks where they're at. So they may or may not be in a place where they're willing to share and to get help and receive services. So you obviously, you want to make sure that folks are safe, especially if they're children, but also realize that, not everybody's ready to share or disclose different things. And then I think Paula really touched on something important is, something that you can do, and it's not going to clue you into who might be, necessarily who, you don't know if they're hiding it. you know, or not, it's not as apparent, but even asking questions and building those relationships and just, you know, building a relationship up where maybe they would feel comfortable, like leaving a door open, you know, for in the future.
Great. Another question that came up during the discussion about meeting basic needs. What type of flexible funding was available, and how was that used to address basic needs? Did you hear that from your partners?
Well, we did hear it, but we heard it as a barrier, really. This project is very heavily funded by, at least ours for Illinois TILs, it's supported by the Victims of Crime Act funding, and it's really geared towards victims of crime. So it assumes that it presumes that there's already that or identification or recognition that someone is a victim.
Well, what I can say, yeah, Paula's absolutely right, but what I can say about the flexible funding that we heard about was it was also sort of like a pilot or demonstration initiative through a state agency. And, you know, whether that will be expanded or not is sort of to be seen. You know, we do have, you know, research here, and like our interviews do show that, you know, are starting to show that things like this are really important to families. So there isn't enough of it, is my understanding. It's like a very small pilot project, but we're hoping, you know, documenting this and showing these things, maybe we can advocate for more flexible funding sources in the future.
Yeah, and there are also some other states who are doing blended funding when it comes to serving clients, and I feel like that might, they show that might work in terms of flexible funding, because it's just one pot that's helping to serve rather than, you know, itemizing services.
All right. Well, I want to thank you both for this really informative session, and I also want to thank all of our participants, especially for your contributions to the list of the indicators of harms and the barriers that you were seeing, and something about the strategies. This has really been an engaging session. Amanda and Paula, thank you so much.
Thank you.
And we look forward to seeing your report.
Yes, absolutely.
All right, goodbye everyone, and last reminder, do take that exit poll on your way out. We will make the slides and the recording available. And again, if you need credit for watching this session, please contact ask@victimresearch.org. Thanks so much, and goodbye.